Okay, good morning, good afternoon to everybody. Thank you so much for joining us. This is the fourth in our series of public health conversations where we talk about topics of interest to UN staff, and this covers any health and wellness topics across the board, and this is for all UN system staff globally. And so this runs out of the UN Division of Healthcare Management and Occupational Safety and Health, which we call DHMOSH. I am the Senior Medical Officer in charge of public health within this DHMOSH division. And so this is something that we decided to do because we feel that there are many staff out there who might be interested in various topics, and we'd just like to give them, good information about that. And this is, it's also a good distraction from all of us away from COVID, as we're always thinking about COVID right now, but it's good to just also focus on other health and wellness topics. So for today, we're really happy to have with us Dr. Koob. And apart from Dr. Koob, we also have three of our UN mental health colleagues with us. The talk will really focus a lot on the physical aspects of alcohol and alcohol use. But at the last, perhaps the last 15 or 20 minutes, we will segue a little bit into UN aspects and mental health aspects. So just to introduce to all of you, you guys all have the bio of Dr. Koob already in your invitation. But Dr. Koob is director of the National Institute on Alcohol Abuse and Alcoholism, and he oversees a wide range of alcohol-related research there. He is preeminent authority on alcoholism, drug addiction, and stress. He has done a lot of research and contributed to the scientific understanding of neurocircuitry associated with alcohol and drug abuse. He has published over 750 peer-reviewed papers and several books, and also mentored PhD students and has over 80 postdoc fellows under him now. He received his PhD in behavioral physiology from Johns Hopkins, and then spent much of his early career at the Scripps Research Institute as director of Alcohol Research Center and as professor and chair of the Scripps Committee on the Neurobiology of Addictive Disorders. He has also served as researcher in the department in the behavioral neurobiology at the Salk Institute for Biological Studies, and he's the recipient of many honors, including the membership in the National Academy of Medicine, and was awarded Knight of the Legion of Honor in France. So we're really, really, really glad that he can join us to talk about this really important topic. It's a really important public health topic, of course, but as well as it's an important topic for the UN community. I'd like to introduce as well three of my colleagues from mental health divisions within the UN. And if we could just mute all of yourselves. Mike, could you just help mute? Yes, thanks so much. So with us, we have Dawn Strayton, and Dawn is as well as a colleague from DHMOSH, and she is a trained psychiatric clinical nurse specialist and psychiatric nurse practitioner. She's worked at the US and Jamaica prior to joining the UN in 2007. And her work is a chief of staff counseling office with DHMOSH. And she has done a lot of work in terms of giving a global view of mental health challenges and psychosocial risks of UN personnel worldwide. She currently serves on the UN Secretariat Mental Health Leadership Team, Steering Committee of the UN Staff Stress Counselors Group, and is an active participant in the development of the UN Mental Health Strategy. Secondly, we're happy to have with us Mohammed Sohail Ali. He is the Regional Stress Counselor for East and Southern Africa in SISMU, within DSS. SISMU is the Critical Incident Stress Management Unit. Professionally, he's a psychiatrist with specializations in community mental health and public health disaster management, and has over 21 years of experience in Asia, Africa, Europe, and currently in the US. Therese Fitzpatrick is the global lead for implementation of the UN System Workplace Mental Health and Wellbeing Strategy. Prior to working with the UN, she has held national and global roles in developing and implementing mental health strategies with specific focus on workplaces and men's health. Therese holds postgraduate qualifications in public health, business management, and occupational therapy. So without further ado, we will move on to talking about alcohol now. What we typically do is we have a very brief overview in terms of presentation on this topic. And then we move on to about 30-minute conversation with me and the panelists, and in this case, Dr. Koob first for the first 30 minutes. And then we'll move over to talk more with our mental health colleagues. Just to say that Dawn has kindly offered to help us with answering questions on the chat. So feel free to put in questions in the chat and we will answer them as the session goes on. So over to you, Dr. Koob. Thank you so much for being with us today.
So it's great to be with you all today. And I just want to make a few points in the beginning that I think will set the stage for any questions you may have about alcohol. I hate to say this, but I probably know more about alcohol than I ever expected to know, given that I've been directing the Institute now for 7 years. So alcohol misuse is associated with over 200 diseases and injury-related conditions. And you can see on this slide that they range from the lung to the gastrointestinal system, to metabolic and neurological disorders. Two of the major ones, of course, are the immune dysregulation and cancers. And it turns out that there's an article today that just came out, it was in our notifications at NIH, that 4% of all new cancer cases in 2020 were due to alcohol or attributed to alcohol. So one of the things that I think is probably relevant to our discussion today is the phenomenon of drinking to cope with stress. So some people drink primarily to celebrate, while others drink primarily to cope with stress and uncomfortable emotions. Unfortunately, in the long run, drinking to cope tends to make things worse. Alcohol temporarily reduces activity in brain areas involved in feelings of stress and anxiety, but activity in these regions then rebounds and overshoots when alcohol wears off, bringing increases in emotional discomfort. With the long term, alcohol causes the brain to adapt in ways that reduce the amount of temporary emotional relief and cause emotional discomfort to become greater in between bouts of drinking. The negative emotional state during abstinence can motivate further drinking and cause an individual to become stuck in an unhealthy cycle. And what I've often said is that eventually a person can end up drinking to cope with the emotional misery caused by alcohol itself. We still okay?
Yes, don't worry. We can mute if necessary. Yes, please go ahead.
So this all begs the question of what exactly is an alcohol use disorder and how do we conceptualize an alcohol use disorder? And we've learned an enormous amount about alcohol use disorder in the brain. And I don't expect you to understand this slide in great detail, but I just want you to realize that we've conceptualized now alcohol use disorder and addiction in general in 3 stages: the binge intoxication stage, the withdrawal negative affect stage, and the preoccupation anticipation stage. And while people start with the binge intoxication stage and they drink for the pleasurable effects, they move to the withdrawal negative affect stage where they end up drinking for the relief that the alcohol has caused, in the sense of the alcohol producing this emotional distress that I was talking about. So while you might initially start drinking to feel good, you end up ultimately drinking not to feel bad. And even during protracted abstinence and into this area that we call the preoccupation, anticipation, or craving stage, you end up relapsing largely because of negative emotional states. And there's a big word on here called hyperkatifia, which is a word I made up basically to describe this negative emotional state that comes from excessive drinking. And we often forget about the fact that basically an individual with an alcohol use disorder is miserable. And I can expound on this later. But we know now from a lot of work in neurobiology, some of which is preclinical, but some of which is imaging work, that during this withdrawal negative affect stage, the reward system is compromised. In other words, you don't feel pleasure like you used to, and the stress system is highly activated. So you end up drinking to fix a problem that ultimately drinking causes. This is really an important construct. So one of the things you can do is examine your relationship with alcohol. It's important to consider your personal relationship with alcohol. If reasons for drinking include reduced anxiety, falling asleep, coping with daily stress or previous trauma, recognize that this strategy ultimately could lead to an alcohol use disorder. We have two sources, the NIAAA Rethinking Drinking, that can help you explore your relationship with alcohol. But we also have in the United States, the Alcohol Treatment Navigator, which can help you learn about and locate resources for treatment and recovery support. Now, those of you in other countries are going to say, well, that's not going to help me. Well, actually, the main purpose of the Alcohol Treatment Navigator is to understand what an alcohol use disorder is and understand the wide range of treatment options that you have depending on the intensity of the alcohol use disorder. And we use the Diagnostic and Statistical Manual in the American Psychiatric Association, which considers an alcohol use disorder a spectrum disorder with a mild, moderate, and severe. And treatments match the severity of the alcohol use disorder. So some people benefit from taking a break from alcohol, and they ultimately cultivate healthier, sustainable options for relaxation and coping. And this has become particularly important during the pandemic, because we've seen in the United States, and I suspect worldwide, about 20 to 40% of individuals have increased their drinking during the pandemic. And a large proportion of those individuals are drinking to cope with stress. For people in treatment and recovery, identifying healthy coping strategies is central to avoiding relapse, because as I said earlier, about 60 to 70% of relapse happens during that protracted abstinence, preoccupation, anticipation, during that craving stage, and it's due to stress. So these are the two resources. I want to just stop at this point and give a special thanks to Rachel Anderson and Aaron White for helping me with these slides. I'm happy to answer as many questions as I can, as you send to me. I will do my very best, and if I don't know the answer, I certainly can try and direct you to places where you can get the answer. So thanks a lot. It's great to be with everyone, and I hope I can help out in some way. So Esther, are you still there? You're on mute. Esther, you're muted.
I think Esther is still trying to unmute herself.
No, right. Okay, sorry. Yeah, Mike, it says host doesn't allow me to be unmuted. So thank you so much, Dr. Koob. That's really a great introduction to us for the in terms of the scientific aspects of this. I'm just gonna pin us both. Mike, can you just pin us both so that we can, let me see if I can do that here. Mike, are you able to pin the two of us?
Yes, you're pinned already, both of you.
Okay, great. Okay, so we're going to move on to some of the questions that we have put together just based on our understanding of what staff might be interested in. You've talked a little bit about the health problems associated with excessive alcohol use, and you mentioned cancers as well. What types of cancers are associated with alcohol, just out of curiosity?
Well, the main type of cancers that are associated with alcohol misuse are esophageal and gastrointestinal, liver, of course, and breast cancer. And breast cancer in particular is important because there's really no safe amount of alcohol when it comes to breast cancer, even sticking within the dietary guidelines that we recommend in the United States, which are 1 drink a day for females and 2 drinks a day for males, standard drinks. There's still, epidemiologically, a small increase in the probability of breast cancer in women. So it's a range of potential toxicity with, of course, dose of alcohol as one of the factors. But there, if you really want to be strict about it, there is no absolute safe amount of alcohol when it comes to cancer.
So you're saying that kind of it's a dose response, and it just starts like from 0, kind of up a gradient, right? So there's no safe level. So basically, all of whatever level alcohol will contribute, or is shown that it will contribute to these types of cancers. Correct?
That's correct. I mean, it's kind of a decision you have to make. I mean, if there's a family history of breast cancer, if you have the gene that's identified for breast cancer, you should talk to your physician about your interaction with alcohol, thinking of the future.
Got it. Okay. So the second question relates to how much is too much alcohol. So you mentioned that there are some resources that people can go in, I guess, to plug in how much they're drinking and figure out. But in general, what kind of markers is being used to determine that for the average person? How would they know?
Well, we recommend the dietary guidelines that are put out by the U.S. Department of Agriculture, and they are 2 drinks a day for males, your average male, and 1 drink a day for your average female, which would be 14 a week, and for males, and 7 a week for females. But there's no absolute, there are just some people who shouldn't drink, Esther. I mean, if you're pregnant, you should not be drinking. If you have a very heavy history of alcohol use disorder in your family, it's something you should think about. If you're Asian American and missing one of the alleles for acetaldehyde dehydrogenase, which is the second stage of the metabolism of alcohol, you're likely to have a flush reaction, which some of you are probably very familiar with. If you try to drink past that flush reaction, you increase the probability of esophageal cancer from alcohol by 10-fold. So, I have friends, colleagues that work at NIAAA who are Asian, and one of them told me he can't drink at all because if he drinks even a few sips and tries to get behind the wheel of a car, he's dizzy, he feels a little faint. So, everyone is different. So you have to make up your own relationship with alcohol. The guidelines we give are the dietary guidelines.
Okay, and in terms of, you mentioned that's kind of the US guidelines. Is it the same in the international WHO context? Is it the similar guidelines that's being used for the definitions?
I believe so. I mean, that's something I should ask you. I mean, I'm not sure exactly what the WHO guidelines are. Be honest with you, I should know, but I don't know. So someone in the audience may know the exact guidelines.
And you mentioned mild, moderate, severe. So these two, when you say 2 drinks for men, 1 drink for women, is that mild kind of use?
No, that has to do with an alcohol use disorder, and the criterion for an alcohol use disorder range from drinking more than you intended to tolerance and withdrawal to impairment in social and occupational activities to craving. There are 11 different criteria, and if you meet 2 of those, okay, so then you would have what would be considered a mild alcohol use disorder. So perhaps getting publicly intoxicated and maybe getting a driving under the influence citation usually would probably put you in the mild category. But if you're suffering from all the other symptoms that I mentioned with severe problems with impairment and occupational functioning. You're meeting 2 criteria there. Tolerance, drinking more than you intended, then you're up to 4 criteria. I mean, at that point, you're in the moderate to severe range, which would be equivalent to what WHO would consider alcohol dependence
Got it. So it's not based on quantity of the alcohol itself. It's more based on behavioral and kind of the effects of alcohol on your functioning, correct? And how badly it affects your functioning.
Right, exactly. So alcohol addiction or alcohol dependence is considered by the ICD, the International Classification of Diseases, would be equivalent to about a moderate to severe alcohol use disorder. And the mild alcohol use disorder is what we used to call alcohol abuse, but we're trying to get away from those terms in the United States.
I see. Okay. So, just kind of speaking and moving on from that, I mean, what would you consider as very early signs of problem drinking? If we know of colleagues or loved ones, what do we look out for? What are some of these very early signs?
Well, I think very early signs are you don't feel right the next day after you've been engaged in drinking. And this is not just a one-off that happened the one time in your life. This is something that's starting to accumulate. But at the same time, another very sensitive measure is impairment in social and occupational functioning. So if you're starting to show up late at work or not finishing assignments, if you're working virtually, or there are increased altercations with family members because of alcohol, because you're disinhibited or you're irritable and cranky, those are early signs that you should be looking at your relationship with alcohol. Is alcohol causing some of the problems that you're having?
Okay, got it. So I'm just going to kind of move the conversation a little bit back to the physical health aspect. I see a lot of people asking about alcohol and weight gain, and I have that similar question as well. What would you say about that? Is that something that is of worry or?
Well, alcohol are basically empty calories, so they will contribute to weight gain, and do so. That can lead to diabetes, and diabetes and alcohol don't mix very well. You're probably going to ask me about that anyway, but we looked it up in the National Institute on Kidney Diseases basically states if a patient with diabetes drinks alcohol, drink moderately, no more than 1 drink a day if you're a woman, and 2 drinks a day if you're a man, with the same dietary guidelines that we espouse. If you use insulin or diabetes medicines, it increases the amount of insulin your body makes. Alcohol can make your blood glucose level drop too low. This is especially true if you haven't eaten for a while. It's best to eat some food when you drink alcohol. So there is a deleterious interaction with diabetes. And of course, it's the same kind of vicious cycle. If you're drinking excessively and gaining weight, then you're making yourself more liable to diabetes, but then the alcohol is actually making the diabetes worse because it lowers blood sugar, and lowering blood sugar can increase your appetite and make you want to drink, eat more. So you get it. And there's the disinhibitory effect too. It's well known with alcohol, because alcohol is often used as an aperitif, and so that's to stimulate stimulate your appetite. And of course, that could be also related to the physiological effects of lowering your blood glucose. So all of these things converge to weight gain and the diabetes interaction.
So, I mean, I guess we would have to say that if someone has diabetes, they really shouldn't be drinking alcohol at all.
Well, again, what NIDDK, one of our sister agencies at NIH that studies, a large part of their portfolio is diabetes, is basically stay within the dietary guidelines. But again, this is something to check with your physician, and it probably depends on the severity of your diabetes and how much it's under control.
And how about blood pressure? Does it have some kind of effect on blood pressure?
Yeah, alcohol can is basically, can lower blood pressure acutely, But in chronic drinking, there's an increase in blood pressure, and it can contribute to hypertension. And the reason that is basically, as I understand it, during withdrawal from alcohol, you have an activated sympathetic nervous system, and that activation of sympathetic nervous system in severe alcohol withdrawal can lead to death because you have hyperthermia. But that includes activation of catecholamines in the periphery, which raise blood pressure. And so hypertension is part of an autonomic activation that you see during withdrawal. Now, you know, the average drinker is not going through that kind of severe withdrawal, but you're getting these mini withdrawals, which I call a hangover, okay? And those mini withdrawals can also include a tick up of blood pressure. And so it's, you know, it can contribute if you have hypertension to start with, if you have the genetics that lead you to vulnerability to hypertension. So again, another thing to consider, all these physical illnesses, physiological effects interact with alcohol. It's, as I said, it's, you know, it can contribute to 200 different disorders. So, you know, it's something to keep in mind depending on your own personal physiology.
So speaking about hangovers, I'm just curious, like, why do they happen? What is a hangover?
Well, you know, again, I go back to my premise, which is I think a hangover is largely you know, what goes up must come down. So it's a rebound phenomenon. It's a mini withdrawal state. Now it's true. It's exacerbated by the fact that alcohol is a diuretic and pulls water out of your body. So you're dried out. You know, it probably exacerbated by the fact that you're probably not sleeping well because of the alcohol, because alcohol helps you fall asleep. It's a small effect, but then you wake up 3 hours later with this hyper arousal, hyperactivated state that I was talking about, and you can't get back to sleep. So, but alcohol withdrawal, alcohol hangover is basically a malaise that is similar, but milder than an alcohol withdrawal state. And so, you know, it's the neurotransmitters that make you feel good are now in the opposite direction. And we call this opponent process, or you know, what I said, what goes up must come down. So if you've had a release of dopamine and opioid peptides when you were drinking, they're a little bit down the next day, all right? And if you, but the other little insidious part is that you release stress hormones and you release stress neurotransmitters in your brain during a hangover, and they make you feel miserable as well. So it's what I call the misery factor. And yet again, it's just like everything else with alcohol. If you stay within the dietary guidelines, you know, there's very little interaction because the brain and your hormonal systems readjust very quickly. But if you excessively use alcohol, then you're challenging these systems. I tell undergraduates when I was teaching, there's no free ride in the brain. You have to pay for everything.
So are you also saying that when people drink, that if people do drink and then have a hangover the next day, this is also a sign that it's too much for them? Or is it normal? Because I always feel that, you know, drinking, you will feel a little bit worse off the next day. Is that like a normal, acceptable thing? Or are you saying that that's not good, and so that you should therefore then titrate yourself such that you don't have that?
Yeah, I mean, with drugs, everything starts with the first administration, no matter what the drug is. And most of the time, the body readapts. That's what I mean, that there's no free ride. So if you are using the drug to relax and feel disinhibited and a social lubricant, I mean, we know alcohol is used worldwide for every meeting. I think you all realize even medical meetings, they start off with you know, an opening reception where they serve alcohol. Even the Research Society on Alcoholism in the United States, you get 2 tickets for 2 drinks to start the meeting, okay? The only meeting I know that doesn't serve alcohol is the American Society of Addiction Medicine. So it's a social lubricant, and those effects are benign, all right, if you stay within the dietary guidelines. And you know, it's like if you drink a cup of coffee, you're going to get wired for a few hours. And then when the coffee wears off, you may get a little sleepy in the afternoon, all right? If you haven't had an additional, perhaps you have a tea in the afternoon to mitigate that little sleepiness. So there's always an action to a drug effect. And with alcohol, there's a mini hangover, maybe you want to call it, or that falls the next day, and depending on how much you've drunk. But when you have a hangover, a real hangover where you feel really lousy, that is a signal that maybe you should reevaluate your relationship with alcohol. That is a signal.
Okay. Yeah, because I remember in university that a lot of some of the students would just come in with hangovers the next day all the time. I studied in the UK. It's really common there, and it's just, you know. So in terms of, I mean, we've talked a lot about the negative aspect, but at the same time, we see research saying that, you know, alcohol is good for you, you know, drink 1 glass a day and all that. So how do you see it from where you sit? Is it okay? I mean, as long as we all kind of is moderate, it's fine, or you know, should we be more on the careful side? And then with regards to predisposition as well, because I saw in your cycle just now, right, that you have some aspects where
who's frozen.
Oh, I think you're frozen.
Okay.
Okay, not yet. Yep. So in terms of, you know, some factors might predispose to alcoholism, and if you have those kind of factors, then maybe you need to avoid totally. So when is it okay, good kind of thing? When is alcohol good and okay?
Well, again, you know, I hate to, you know, keep repeating the issue, but I think each person has to evaluate on their own their relationship with alcohol. The guidelines that we stand by are the moderate, you know, the guidelines of the U.S. Department of Agriculture, you know, and so the 2 drinks a day for males, 1 drink a day for females. But for some people, maybe it's only a half a drink. You know, alcohol is a social lubricant, as I said, and it's widely used, and probably millions of contracts across the world have been signed. Thousands of scientists have conceived of collaborations with fellow scientists at meetings, you know, in these kind of situations. So, you know, often we argue that the beneficial effects of alcohol in this social lubricant domain. From a physiological point of view, the only data out there that suggests that alcohol is beneficial is the data on heart attacks, and in fact, strokes, which are other cardiovascular disorders, are exacerbated by alcohol. And the data for heart attacks is just not that compelling. You know, large epidemiological studies suggest that moderate consumption is associated with a reduced risk of heart attack, but at what cost for other disorders? Remember what we talked about with cancer, and particularly breast cancer. So I think that, you know, prohibition didn't work. You know, I'm not a prohibitionist, but I do urge Americans in particular, and everyone in the world, to examine their relationship with alcohol, stick within the dietary guidelines, and understand that more is not better with alcohol. And that holds for many drugs. You know, we always assume that because, you know, a little bit of aspirin is good for arthritis, that a lot of aspirin is even better for arthritis. And that's not necessarily the case, because aspirin is going to cause gastrointestinal lesions. But with alcohol, it's even more poignant. You know, 1 drink may be wonderful for interacting at a dinner party when you're eating and enjoying yourself. But, you know, 4 drinks is not, right? It's just not better than 4 times better than 1 drink. In fact, you're going to be turning the corner.
Right. Okay, before we move on to some of the questions on the chat, just 2 very quick questions from my side. One is relating to children and alcohol. You know, in some cultures, they expose children to alcohol, but of course in the US, you're not supposed to do that. But do you have any thoughts on that?
Yeah, there's a lot of misconceptions in that domain. You know, people in the United States think in Europe that they train individuals to drink properly, and that's just not the case. The French ambassador came up to me several years ago and told me we have a very big problem with binge drinking in young people in France. So, you know, and then the other part is a lot of studies have been done in the United States about hosting parties. These were parties where parents brought their kids together and hosted an alcohol drinking event. And it turns out that it did not prevent problems with alcohol. It actually trained young people to be binge drinkers, because the people that were coming to the party were already kids that were binge drinking. And so the hosting idea has just fallen by the wayside in the United States. There's no evidence to support it. In fact, the evidence is in the other direction. So you know, I think the position in the United States of 21-year-old drinking age is the right position. The brain doesn't fully develop until about the age of 21 to 25. And I often say in the United States, if you've ever raised a teenage boy, you know what I'm talking about. And so, you know, alcohol interacts with that developing brain. We're gathering more and more information about the deleterious effects of alcohol and in speeding up some of the culling of neurons in the frontal cortex, but also reducing the connections from the frontal cortex to the brainstem that occurs with excessive drinking in adolescence. And these are changes that lead then to a vulnerability to alcohol use disorder later in life, among other things, not to mention possibly other mental issues. And so I think, you know, and I think a lot of other countries are starting to adopt a more strict rule for drinking with children. So, you know, the best plan is, and then finally, there's the behavioral piece.
I'm doing fine.
Hi, there's somebody, I think Gianni Longo, you want to mute yourself?
Anyway, the last thing I was going to say very quickly is that, you know, we as adults are setting standards for young people, and that's an important part of self-regulation, the standards we set. Just think of the first time you used a bad word in front of your child, and you realize it's stuck in there now forever. And so if they see you misusing alcohol, they're going to misuse alcohol.
Great. And then just one last question from me, given that you're the expert on neuro circuitry and the reward kind of behavior, how do we actually cut that circuit, you know, of alcoholism and addiction? What are the really evidence-based tools that we can do that?
Yeah, that's a good question, Esther. And so there are behavioral approaches like cognitive behavioral therapy and motivational interviewing that are very effective in treating alcohol use disorder. Motivational interviewing may require, and both may require a trained, you know, clinical psychologist to get you on your way. There are 3 medications approved in the United States that will help people on their way. Naltrexone will blunt the reinforcing effects of alcohol and pleasurable effects. Acamprosate tends to help with that malaise that comes on late and helps prevent relapse. Those are some of the concrete examples. Time, exercise, time of abstinence, exercise, all of these things can help your brain recover. You don't grow the neurons back if you've ruined some of the pathways in your brain, but you can strengthen other neurons, much like you would do if you were if you had blown your anterior cruciate in your knee and had to use you know, go into an exercise program to strengthen the muscles around your knee so that you could go back to skiing, maybe with a brace. And I think the brain works in the same way. You may not be using the major highway anymore, but you're using the side roads, and you can strengthen those side roads with all of the things that I mentioned, from medications can help you along the way to the behavioral treatments. Behavioral treatments do change the brain. I think that's something really important to emphasize. It's not just with alcohol use disorder, but mental illness in general. Behavioral treatments, effective behavioral treatments, not only help the behavior, but they change your brain and strengthen it for resilience for future problems.
And what percentage would you say worldwide and in the US that people are truly recovered versus relapsing chronically? Because, you know, in our community, we do see a lot of relapses as well, and just curious to know.
Yeah, I've been asked that question a lot lately, and it's a little bit difficult to answer. You know, we have about 14.5 million individuals with an alcohol use disorder in the United States. In any given snapshot of treatment, about 10% of those treated will actually recover and And
10%, okay.
and that's, and you know, I just don't know how many are getting treated, but it's less than 10% of the actual individuals with alcohol use disorder. So, you know, you're talking about, if you do that, you know, it's about 1% of individuals at any given period of time in the United States are actually recovering. And, you know, it's one of the biggest issues that we're facing. We really need to get more people into treatment in the United States and across the world. I just think that's one of the biggest gaps.
So you're saying that 10% of the people are being treated, and then out of the 10%, another 10% of those would recover. So in total, it's basically a 1%.
Correct.
Right. Okay, got it. Okay.
And that's just a rough estimate. You know, that's not written in stone and not in a paper in the Journal of the American Medical Association. I'm just giving you a snapshot.
Got it. Okay, great. Thanks so much. So I'm going to just move on quickly. We have tons of questions that came in. I'm going to start from the bottom up. Someone asked about naloxone. Do you know if that works? Is that something that you would recommend?
Yeah, the drug is naltrexone. Naloxone is used for opiate overdoses, and it's not used in alcohol use disorder. Naltrexone is the orally active, long-acting version. It's also in an even extra long-acting depot that's called Vivitrol, which is an injection, and that lasts for about 6 weeks. And yes, naltrexone is an effective medication for the treatment of alcohol use disorder. It blunts the reinforcing, the pleasurable effects of alcohol. And so people maybe take a drink and they go, you know, it didn't do much for me. And so, you know, it helps prevent them from engaging. The other drug is acamprosate, which was developed in Europe originally by a French drug company. And that is effective in helping prevent relapse. And it has a similar effect. Both drugs have similar effectiveness. People don't realize this. They have similar effectiveness in large studies that have been done across the world as serotonin selective reuptake inhibitors for depression. So these drugs are effective. They're just not used, unfortunately.
Okay. Another question, in West Africa, we have palm wine, and apparently it has great health benefits. Do you know anything about that particular type of wine?
No, I mean, you know, alcohol is alcohol across the world. I mean, when there's alcohol involved, everything that I've been talking about plays.
But there's no differentiation of the types.
No, I have never heard of one alcohol being better than another alcohol. I mean, some have sugar in them, and that might make you want to drink more and not realize you're drinking more. So, you know, some of the concoctions can have deleterious effects because you don't notice that you've just taken in the equivalent of 3 standard drinks.
Okay, and a question that a lot of people are asking is, what constitutes one drink? Is it an 8 ounce?
8 ounces of beer, 1.5 ounces of 40% alcohol in something like bourbon or whiskey, and 5 ounces of wine. That's how we define it in the United States.
Okay. So, I mean, we can send out the link and the standards.
Yeah, the Rethinking Drinking. So anybody really interested in all these facts I'm throwing out to you, just type into your search engine Rethinking Drinking or the NIAAA website and then go to Rethinking Drinking, and you'll get a lot of this information. There's a beautiful chart there. You can even type in Rethinking Drinking your favorite mixed drink and find out how much alcohol, pure alcohol, is in it.
Okay, great. Another question, effects of alcohol on fertility. Do we know of anything? But I mean, obviously someone who's pregnant or breastfeeding shouldn't be drinking at all.
Correct.
Yeah.
Shouldn't be
because
drinking
of the effects
all.
on the fetus, right?
Right. I believe there's old data that if you're really misusing alcohol, it can have deleterious effects on sperm count. And to be honest with you, I haven't visited that literature in a long time. You know, alcohol, you know, the famous quote by Macbeth, in Macbeth, you know, it improves the desire but decreases the performance. So alcohol, you know, can stimulate through disinhibition, sexual encounters, but
Right.
it can also have deleterious effects on the actual sexual act. So depending again on the dose. So, you know, everything with alcohol is related to how much you're drinking.
Another question, can you say something about genetic inheritance, so genetics and alcohol personality types? Not sure what's alcohol
That's an
personality
old story that there's an addictive personality. I think we now would break that down into multiple components. Some people are impulsive. Some people are very impulsive because maybe they're suffering from attention deficit hyperactivity disorder. Some people are inherently in a negative emotional state. They may have dysthymia or major depressive episodes. Some people are chronically anxious. All of these things can help you enter the addiction cycle in different stages. And so people will often label them as they have an addictive personality. But in fact, what we know is, you know, and some may have cognitive problems that can be derived from anything, you know, environmental influences, trauma when they were or abused when they were children. All of these things can contribute to the vulnerability to alcohol use disorder, because you can enter that cycle I showed at the beginning, the 3 stages, the binge, intoxication, withdrawal, negative affect, or the craving cycle at any point in that cycle. And where you enter that based on your makeup can determine you know, your vulnerability to an alcohol use disorder. So we don't think of addictive personalities anymore. And as far as genetics go, you know, and there's a genetic loading to all of these issues. You know, some of us are more likely to have heart disease, and some of us are more likely to have diabetes, and some of us are more likely, for a variety of reasons, to perhaps have negative emotional states. You know, that maybe you were born with a you know, polymorphism in a gene that's controlling one of the brain stress systems. And so we know that some of these things, that in overall, alcohol use disorder and substance use disorders in general have an heritability about 50 to 60%. And so there is a genetic component, but it doesn't, you know, it's not a life sentence by any means. I mean, there's an interaction I've already, you know, discussed with the environment, obviously.
Okay.
And then some people, just for the record, are protected in the sense that if you're missing that allele for acetaldehyde dehydrogenase, you may not drink at all because you get a flush reaction, and it's just not in your best interest to be so compromised. And so in that sense, you know, there's a genetic protective factor. On the other hand, if you drink past that, we've already discussed, that can go to the other side.
Great, thank you. What are your thoughts about replacing alcohol with synthetic alcohol, like Alcosynth?
Yeah, well, I have to say that I'm personally skeptical. I know David Nutt, who's one of the proponents of this concept, and he's a wonderful scientist and a great clinician, and he's done a lot of great work. And so maybe it'll work out, but I'm not optimistic because of what I said earlier. What goes up must come down. I just don't see free rides for the neurochemistry in your brain. So if you're starting to modify the neurochemistry of your brain, there's going to be some payback at some point.
Question about, are there some types of ulcers that are caused by alcohol? You mentioned the association with gastroesophageal cancers and stuff, but I assume that some of the gastritis and gastric ulcers perhaps might be associated as well.
Yeah, alcohol at higher doses can cause gastritis, but more importantly, it can cause destruction of the mucosal lining in the stomach and small intestine, which can lead to bleeds, gastrointestinal bleeds. And so it's not unusual. I've seen many of these during my time at NIAAA, where we'll get a call from a colleague that their nephew is in the hospital with a GI bleed, a gastrointestinal bleed, and in very serious trouble. And when they've gotten it under control in the emergency room, they want to get him into a treatment facility. So it's the GI bleeds for excessive alcohol use a bout of excessive alcohol use are not unusual. I think it's more likely to be the case than ulcers.
Yeah. How would you compare the use of alcohol to the use of cannabis? I mean, are they similar in terms of addiction patterns or?
Well, one of the untold facts is that cannabis is also produces cannabis use disorder or addiction, and it afflicts about, the last statistics I saw, about 9 to 10% of users, which is actually higher than that of alcohol, which is about 6% of users in the United States. I think that that misuse of cannabis has a lot of deleterious effects from the perspective of addiction. But there are other effects, including cardiovascular ones, cognitive effects. There's a major concern with excessive cannabis use regarding psychotic episodes, particularly in some individuals. So this is an evolving area. It's not my domain. It's the domain in the United States of the National Institute on Drug Abuse. But I know from my colleague Nora Volkoff that I think what I just said, she would also probably say. As far as one of the things we're concerned about, and we're following with some of our contracts that look at policy changes in individual states across the United States, is what is the interaction between alcohol and cannabis. And I would worry about individuals who are using both drugs, and we don't know the numbers yet, but this is something we'll be looking at in the future.
Okay, great, thank you. Just maybe one or two last questions. You mentioned just now that you're not a prohibitionist, so you're not, I guess you're not anti-alcohol in that sense. So a question is, from a public health perspective, how can various institutions around the world educate and prevent with respect to alcohol use disorders? Should it be kind of the individuals being aware of their vulnerabilities, or should we be kind of anti-alcohol?
Well, I think it's the former and not the latter. I think you really need to make sure that that individuals are aware about alcohol, and this should be part of our basic medical education. And so what we're trying to do is really work with a variety of institutions in the United States to increase training of physicians, but all clinical researchers. We're working on something we call the Clinical Core Resource, where we will have everything you need to know about alcohol spelled out for individuals who work with patients, and that ranges from pharmacists to nurse practitioners to nurses to clinical psychologists to primary care doctors to board certified addiction medicine specialists. So that's one piece. The other part is, really getting uptake of treatment and getting physicians and clinicians and everyone involved in treating individuals to ask how much a subject is drinking, how much is a patient drinking, and then if they actually report that they're drinking excessively or having problems with alcohol or having those repeated severe hangovers, to then get them into some form of treatment or referral to treatment. So I think these are the challenges we have. Prohibition doesn't work from a public health perspective because people find a way to make alcohol. I mean, look at the prohibition that took place in the United States and Europe, and you'll see the pattern of results. I can tell you for a fact that liver disease decreased dramatically during prohibition. The deleterious pathological effects of alcohol decreased dramatically during prohibition. But on the other side, there was a great increase in crime and misuse of alcohol that was uncontrolled, and preparations of alcohol that were unregulated, and it got out of hand from another perspective of public health. So you in public health have to weigh these balances between one side and the other side of the effects of something like alcohol.
And how about any kind of strategies that could be adopted by countries? We have a question here, for example, increase legal age of drinking, increasing tax on alcohol, limit advertising. So is there anything that has been proven effective in throughout the world, or?
All of the above, but I would particularly emphasize the increase in drinking age in the United States has produced a straight line decline in problems of drinking with young people.
Mm-hmm.
We've had a straight line decline in deaths on the highway in the United States that parallel this change in the drinking age. It has been very dramatic. So that I can speak to.
And
all
it
the
used
other
to be what age versus now?
Some states it was 18.
And now it's
21.
21. It's across the board 21.
Yeah, across the board 21.
Okay.
And also the blood alcohol level legal limit is across the board 0.08 in the United States. One state, I believe Utah, has dropped it to 0.06. And Europe is even stricter, but that has also contributed to the decline in drunk driving and deaths on the highway. So all of those things have converged. As far as the other factors, anything that limits the availability of alcohol will decrease consumption. And it's a question, again, of balance. Because if you increase taxes, if you decrease outlets, if you decrease, the age that young people can drink, all of those things are going to limit the availability of alcohol, and that's going to limit consumption.
So can I ask you kind of if, on a more practical level, if someone, whether the US or somewhere, determine that they have an issue, they go to their practitioner. I mean, but not, a lot of clinical people don't know how to deal with such an issue. What can they do? Is there like a number that they can call, or?
Well, we have the NIAAA treatment navigator. And so, that's a first start. And I hope by the end of the year, we'll have what we call, loosely, it'll have probably a different name, the clinical core resource out on our website, and that should be available. And so, I think a first start for anyone would be to go to the NIAAA website. I mean, we are the evidence-based source of information for alcohol for the whole world. We fund the most alcohol research in the whole world by hands down. And, we welcome your input. Our website is a living document now, so we can change it. So if there's something you want added, we welcome your input. We just put out a request for information for our strategic plan for the next 5 years from 2022 on. So, we welcome inputs from worldwide. It doesn't have to be the United States, of things that perhaps we should be doing that we're not doing. So, we embrace your input and your thoughts.
Okay, great. Thank you. Thank you so much. I think we're done with time, and we're going to move on to internal kind of UN policies and stuff like that. So Dr. Koob, you're welcome to stay with us, but I know you're busy, so feel free to leave as well. But thank you so much. Any last words of advice for us, or anything that you want to tell anyone, all of us here?
No, I really appreciate the questions, and I really appreciate everyone's interest. And just remember what I said about alcohol. There's no free ride in the brain, and there's no free ride in the body. All right.
Great. Thank you, Dr. Koob. And we will be posting this online as well for those who can't join us. Thank you so much.
So I'm going to say goodbye because I have to move on to another symposium.
Yes, please go ahead.
Great to see everyone. And
thank you, Dr. Koob. Bye. So for everyone else, we're going to just stay on, and we're going to have our UN mental health colleagues just to introduce themselves a little bit. And then, Dawn has been helping with the chat already. Dawn, do you want to just start off to say anything?
Sure. Just say hello to everybody. I've been individually answering some questions to people, but also, if it looked relevant, sharing it in the chat. Unfortunately, the UN website, the UN.org website, is down at the moment, but I did share in the chat, and I can send it to Esther to share along with the follow-up email, that there's a Corona website, a well-being page in that and it has on the right-hand panel, there's a lot of information of, self-care and some guided meditations and various resources that are useful for every day, not just during COVID, but there's also links to how to contact a staff counselor. for different organizations. It also has a link to my team as well as to the SISMU team that Sohail is going to speak of for field personnel. And then we can help you find the counselor that's appropriate for your organization and location. So don't hesitate to reach out. There's also how to find an external mental health professional. So for people with Cigna, Blue Cross, Aetna, they all have set up some type of telehealth services during COVID. So you can link with psychologists or psychiatrists directly through their individual telehealth. And that's all on that website. So once the UN website's back up, you have access to all of that.
Okay, great. Thanks so much, Dawn. And over to you, Sohail, to talk a little bit about SISMU.
Yes, let me see if my camera is working. Can you
Yes,
see
your
me?
camera is working fine, yeah.
And you can hear me as well.
Yes.
Okay, so those two things are working. That's the celebration when both audio and video work. So thank you, Esther, for such a wonderful discussion. I'll be brief. Just to introduce everybody, I'm from the Critical Incident Stress Management Unit in UNDSS. I'm the Regional Stress Counselor for East and Southern Africa. But SISMU is the global coordinator for stress management services across the UN, and especially in field environments. So in the field missions, as well as the country offices, we provide counseling support to personnel and their family members. And a lot of the time, the services are underutilized because of lack of awareness.
Mm-hmm.
I can tell you that practically we have a presence in almost every country around the globe, either in the form of our own counselors with DSS or DPKO, which are over 100, and then our partner counselors in the agency funds and programs, which are close to 100 as well. And then where in the countries where we don't have internal UN counselors, we have external psychologists and psychiatrists, mental health professionals that are affiliated with us. So we can refer you to them. So overall, we have the globe covered in terms of presence. It's just about accessing that support. So how can you access that counseling support? We get that question quite often. Please, if you're in an agency that has a staff counselor, please do get in touch with them. If you're in a location where your agency does not have a staff counselor, you can contact with the local UNDSS counselor, with the local DPKO counselor. If you don't have knowledge about who those people are, you can drop an email to undssismu@un.org, and we will guide you in the right direction of who is available in your location so that they can provide you support, which is fully confidential. It's not shared with anybody, with management or with other people in the mission. And we will guide you on what resources are available in your location that you can utilize. Which brings me to the next point, which we get asked about often, is that are there any risk factors that are specific to the UN in terms of alcohol dependence? And I can speak about the field, especially for the peacekeeping missions and non-family duty stations, that there are risk factors in the sense of the isolation that happens in these locations, the lack of social welfare and activities and outlets. Sometimes the only way to relax is to get a drink or to go to a bar. And the fact that they live in sort of a fishbowl where the interaction with the local community is minimum, and your colleagues are your friends, are your colleagues every day. So those very closed environments, those very isolated environments, the lack of social support and the separation from family members become causal factors as well as aggravating factors with alcohol use disorders. And the other challenge is that in many locations in the field, we don't have rehab services, you don't have detoxification services, which then need to be sent to another location for the person to get those services. So those challenges are there, and they aggravate the situation further especially when people come back after recovery, they're in the same fishbowl environment again with the same challenges, and the relapse rate is very high. One takeaway that we would request everybody to think about is that the way Dr. described it, and Esther and Dawn described it, it's a disorder that affects both physical health, psychological health, emotional health, social well-being, spiritual well-being. Everything is affected, and the management is equally multidisciplinary as well. If, as a manager, you want to be able to help your team members or yourself, please go for a multidisciplinary management involving the local staff counselor or stress counselor, the medical physician, the UN physician there. HR needs to be involved. If there are performance issues, the manager needs to be involved. That's the only way for effectively managing these. If you go for a multidisciplinary approach from the start, when the problem is identified, and follow it through. Otherwise, the relapse rate will remain very high. And to close off, I'll just say that there are resources available. Please feel free to access them. They are confidential resources. If you don't know who your local stress counselor in your country is or the staff counselor is, please just write to undss@un.org, and we'll make sure that you're connected with somebody in your location or in your time zone that can help you out. So
great. Thank you so much, Sohail.
Okay.
Much appreciated. Yeah, we will link all these resources, kind of a one-stop shop, so that we can kind of send it out all at the same time. And then last but not least, over to you, Therese.
Thank you, Esther, and thank you to George and my colleagues Sohail and Dawn. You can see it's really a team effort across multiple departments when we're thinking about alcohol use as well as mental health issues. So as Esther said at the start, I'm the global lead for the implementation of the UN System Workplace Mental Health and Wellbeing Strategy. The strategy was launched in 2018 and we commenced work on it in 2019, and we'll share details of that within the chat, because I think it's really important that everybody is aware of the work that's happening across the system. There's a few links within some of the work we've done related to alcohol use. And when the survey launched, it was after a survey that was done when the strategy launched after a survey done in 2015, which showed a number of issues related to mental health of UN personnel, one of which was high levels of hazardous drinking. And I won't go into the details around that, but the link to the survey is on our website. Another survey we did last year, this is a system-wide survey that 13 UN organisations took part in, showed that 14% of UN personnel who took part in the survey showed that they had greater use of alcohol over the COVID period, which was the survey which we did in May and June last year, which was obviously a stressful period for many, but it showed that a lot of people were turning to alcohol as a means to cope over that period. The next survey, we are in the process of collecting more data, and this is now a broader survey that is about all health issues across the UN system. There's over 20 UN organisations taking part in that, and we'll share the links with that in the chat as well. So we encourage all UN personnel to take from those organisations to take part in the survey, because it will really help us understand policies, services that we need for all health issues going into the future. The mental health strategy is quite broad, so we focus on creating a healthy workplace. How do we actually think about preventing poor mental health? How do we make sure we've got a workplace that's actually really conducive to good mental and physical health? We look at how do we make sure we support people who are experiencing mental health conditions, whether through making sure we've got policies in place, we're reducing stigma, and obviously making sure we've got psychosocial services in place. So we work closely with our counselling colleagues, with our public health colleagues, with HR, with staff federations, to make sure we're putting steps in place to improve mental health and wellbeing for all UN personnel. So you can see from the work of Sohail and what we've heard today, all of this, obviously the focus is on all of our mental health and wellbeing, and that is related obviously to alcohol use as we talk about this. Alcohol use can increase our risk of poor mental health, just as people can turn to alcohol when they are experiencing poor mental health as a way of managing that. So we've got a whole range of different activities going on. We've recently launched some resources for leaders and managers about how to look after your own mental health, as well as how to support staff who are experiencing poor mental health. Again, we'll put the links in the chat as well as our contact details. So I encourage you all to reach out, look at the resources, as well as obviously the resources on the COVID UN website, and do take the time to look at those and think about how we can all take steps to look after the UN's mental health and wellbeing. Thank you, Esther.
Great, thank you so much to the three of you mental health colleagues here. You know, this really started off really as a public health, focusing on physical health, but of course there's so much relationship between the two anyway, so it's really great to have all three of you with us. And so without further ado, we will close. Our next session will likely be on obesity and weight loss. A lot of people are asking about that, and so we might do that maybe in August or maybe September. We may also have something on infectious disease coming up, but just look out for it. We'll send the announcement when it's ready. All right, thank you everyone, and we will send this recording out soon, and you can share with your colleagues. Anyone who is interested in this topic, please share with them. So goodbye and have a good day ahead. Thank you. Bye everybody.